Welcome to the Explainer. Look, if you're managing patients with chronic liver disease, you already know the clinical landscape can feel a bit like, well, navigating a minefield blindfolded. The stakes are incredibly high, the pathways are complex, and the data, it's constantly evolving. But today, we're going to fix that. We're breaking down the ultimate clinical map for the cirrhosis patient journey. Think of this as your masterclass in stratifying risk, optimizing care, and ultimately saving lives.
I want you to really listen to this guiding principle. CSPH is the single most important determinant of prognosis and surgical outcomes. Clinically significant portal hypertension. If there's literally one concept, one underlying driver you absolutely must hold in your mind as we go through this algorithm, it's this. Identifying and managing CSPH is the bedrock of predicting how your patient is going to fare, whether they're stepping into the OR or just trying to avoid decompensation. It is the silent engine of this disease.
Okay, let's dive into this. We're navigating this framework in 6 clear steps. Initial diagnosis, the etiology workup, assessing portal hypertension, prognosis and risk, managing decompensated cirrhosis, and finally, the transplant pathway.
Starting right at the beginning with Section 1, Diagnosis and Initial Stratification. This is your patient's entry point.
Here is the complete cirrhosis patient journey, the master map we're working from today. I know, it looks a bit dense right now, but don't worry, we're going to zoom in and examine the specific, actionable forks in the road. The entry point here relies on clinical evaluation, imaging, and critically, elastography. Why is elastography such a game changer here? Well, because it shifts us away from relying purely on invasive biopsies. It gives you rapid, bedside risk stratification that fundamentally alters how fast you can triage and jump to intervention.
10. That is your magic number for peace of mind. If a patient's liver stiffness measurement, or LSM, on transient elastography is under 10 kilopascals, that is highly reassuring. If they score under 10, you can definitively rule out advanced disease. It's a hard, fast stop that prevents unnecessary invasive testing down the line. But what happens when that number climbs? Between 10 and 15, we've got to suspect compensated advanced chronic liver disease. And at 15 or greater, we have to start considering portal hypertension.
Now, what's really interesting about this is how it establishes the core inciting incident of our pathway, that critical divergence between stage 2A and 2B. On the one side, you have compensated cirrhosis. The patient has 0 clinical complications, no ascites, no hepatic encephalopathy, no variceal bleeding, no jaundice. But on the other side, decompensated cirrhosis. The presence of any of those 4 complications immediately shifts your patient into a high-risk category. This binary split dictates literally every decision you're going to make from this moment forward.
Moving to Section 2, the etiology workup. This is where we put on our detective hats and hunt for root causes. And we do this for absolutely all patients.
This workup has to be exhaustive. We check for viral causes, hepatitis B and C. We're taking a detailed history for alcohol use. We screen for MASLD by checking BMI and metabolic syndrome indicators. We're running autoimmune panels, ANA, ASMA, IgG. And we definitely don't forget genetic or other factors like iron studies, ceruloplasmin, or alpha-1 antitrypsin. You might wonder, why be so incredibly thorough? Because removing the etiological factor has an almost surprisingly disproportionate impact on patient survival. Stop the injury, and you can fundamentally alter the trajectory of the disease, even in patients you might think are already too far gone. Clinical data actually continually reminds us that viral clearance or sustained alcohol cessation can halt decompensation in its tracks, radically improving quality of life.
All right, now we're entering the primary danger zone. Section 3, assessing portal hypertension. If your patient has an LSM of 15 kilopascals or greater, they enter this critical pathway. Before we assess it, let's establish a crystal clear baseline definition. Clinically significant portal hypertension, CSPH, is definitively defined by a hepatic venous pressure gradient, or HVPG, of 10 millimeters of mercury or greater. This is the physiological threshold where the whole game changes. Hitting this mark predicts decompensation, it predicts varices and bleeding, it determines whether you need non-selective beta blockers, and it heavily predicts surgical outcomes. So determining if your patient actually has CSPH is basically a 4-step process. Step 1, rule it out. If LSM is under 15 and platelets are over 150,000, CSPH is ruled out. Step 2, rule it in. If LSM is over 25 in non-obese patients, or if you see varices on endoscopy, CSPH is confirmed. But step 3, that's the clinical mystery. We call it the gray zone.
When steps 1 and 2 don't neatly apply, we can't just guess. Instead, we turn to enhanced non-invasive models. You've got tools like the Anticipate model looking at spleen stiffness, or the NICER model incorporating BMI, or the Vitro score analyzing the von Willebrand factor to platelet ratio. These models calculate individual probability, so you only proceed to step 4, the invasive measurement, if the results will actively alter your surgical plan. Utilizing these gray zone tools effectively saves your high-risk patients from unnecessary invasive procedures while still arming you with absolute precision data.
So the crucial point is 16. If you do proceed to an invasive measurement, an HVPG of 16 millimeters of mercury or higher, that equates to an explicitly increased surgical risk. And if that pressure climbs to 20 or higher, you are looking at extremely high surgical risk. These are the hard numbers that should make a surgeon pause and reconsider their entire approach.
And that leads us right into the mathematical portion of our explainer. Section 4, Prognosis and Surgical Risk. Because every cirrhosis patient being considered for surgery needs a rigorous, objective evaluation. We rely on 2 classic pillars here for severity and prognosis. First, the Child-Pugh class gives us a functional snapshot. Class A is well compensated. Class B indicates significant compromise, and Class C means the patient is decompensated. Alongside that, we use the MELD-NA score, which is absolutely vital for transplant consideration. A MELD-NA of 15 or greater is your definitive trigger for a transplant referral. And remember, a MELD-NA over 20 signals a very high mortality risk.
And this brilliantly illustrates what happens when we talk about general surgery. This is where the vocal pen score shines. It's your core tool for calculating preoperative risk in a cirrhosis patient. Notice how it doesn't just look at liver function. It factors in age, albumin, bilirubin, platelets, obesity, and MASLD presence. Crucially, it also integrates the ASA class, whether the surgery is an emergency or elective, and the specific type of surgery being performed. It's incredibly comprehensive, and it dictates whether a patient gets standard care, needs intensive optimization, or if surgery is just contraindicated altogether.
Okay, picking up the pace a bit here because now we're dealing with a crisis. Section 5, Managing Decompensated Cirrhosis. The goal shifts completely from preventing that first decompensation to preventing rapid progression and managing complications head-on.
You absolutely must recognize exactly where your patient falls on the acute on chronic liver failure, or ACLF, spectrum. It starts at stage 1, stable decompensated. It can progress to stage 2, unstable decompensated, then to stage 3, pre-ACLF, and finally stage 4, ACLF, which is strictly defined by the presence of organ failure. Let me be clear, reaching stage 4 carries the absolute highest mortality risk on this entire algorithm. You do not want your patient reaching stage 4.
Managing all of this requires rapid-fire, multidisciplinary intervention targeting specific pathophysiology. Got ascites? We deploy diuretics, large-volume paracentesis, and maybe consider TIPS if it's refractory. Hepatic encephalopathy? Get them on lactulose and rifaximin. A variceal bleed? Endoscopic variceal ligation, vasoactives, and potentially TIPS. And for infections, like spontaneous bacterial peritonitis, early aggressive antibiotics and prophylaxis are absolutely mandatory. In a decompensated state, hesitation is your biggest enemy. A unified, multidisciplinary approach from the jump is what separates survival from rapid decline.
If your patient has decompensated, we've reached the most consequential phase of the algorithm. Section 6, the transplant pathway. I really want you to absorb this clinical mandate. Early referral improves outcomes. Do not wait for multi-organ failure. This isn't just a suggestion, right? It is an absolute requirement. Any decompensation, a MELD score of 15 or greater, or a poor quality of life due to cirrhosis should immediately prompt a liver transplant pathway evaluation. Early referral is literally a lifesaver. Let's move to and see how this builds directly into an incredible option, the living donor liver transplant, or LDLT. This proactive pathway drastically reduces waitlist mortality and is especially useful for patients who might have a lower MELD score but remain highly symptomatic. To qualify, though, a patient has to meet strict prerequisites: no active infection or sepsis, documented alcohol abstinence, adequate cardiopulmonary reserve, psychosocial suitability, and a high potential for adherence. With careful donor selection and high-volume center expertise, LDLT offers a viable bypass to the brutal arithmetic of the transplant waitlist.
Well, we've mapped the entire algorithm.
From that very first liver stiffness measurement, right through the gray zones of portal hypertension, straight into the urgency of decompensation management and the transplant pathway. You now have the framework to confidently assess risk and optimize care for every single cirrhosis patient that walks through your door. So my final question to you is this. Armed with this algorithm, will you refer your next decompensated patient in time? Keep learning, keep pushing the standard of care, and thank you for joining me on this explainer.